So good evening and welcome to our discussion this Saturday. I am your host, Dr. Nema Araka, and today we are continuing with the discussion of psychosis. Last week, we looked at psychosis in women and we learned about the very many similarities that the different kinds of psychosis, how they present with men. So both genders seem to have similar incidences and similar ways of presenting with psychosis. Today, we want to see men, but not to stigmatize them, just to understand some of the differences they may be there and the similarities that exist between the two genders. Our panelists today, we're going to learn from Professor David Ndete, a psychiatrist, who's going to be teaching us a lot today about psychosis. So welcome this evening, Professor Ndete.
Thank you very much. Pleasure to be here. Thanks for having me.
Thank you very much for making the time. So the questions that we were looking at are the same ones we did last week. So perhaps we can get a quick refresher on just a basic understanding of psychosis. Ndete.
Yeah, psychosis is a broad term that encompasses very, very many conditions, ranging from schizophrenia. Schizophrenia has got very many types of psychotic symptoms. We have depression, especially major depression. We have organic conditions. We have substance-related conditions. And the list goes on and on and on. We have also other conditions which are really psychotic in nature, but they are neither schizophrenia nor mood disorder as such, but they are a certain way of expressing culturally accepted way of communicating mental illness. We can go into those details later as we go along.
Okay. Thank you very much. Now, psychosis between men and women, how does it present?
Well, let me just start by saying this, and I want to make it very, very simple for the viewers so that we can put everything in proper perspective. Every time anybody does research, there are certain things they must look for and they must ask. And if they don't ask that question right from the beginning, it will be very difficult to interpret those conditions. I mean, their findings. We know sex that is gender is very important. We know age is very important. But we also want to ask many other things. I'll probably put this into maybe 3-4 categories. Number one, we want to understand the biological or genetically related conditions that may be present in different ways, in different conditions. We want to understand their psychological status, personality, and things like that. And we know for sure that human behavior is determined by the genes in about 75–80%. So the behavior that we have to a large extent is determined by what we inherited from parents. And this behavior ranges from intelligence, personality disorders, and things like that. So if you are a very highly successful, intelligent person like you, Nema, it's very important for you to know that never boast about it, because you had nothing to get it. You inherited it from your parents in about 80%. But we know that even when you have a genetic predisposition, the environment is very important. The environment may involve where you live, your employment status, your financial issue, the relationship with people, extremely important. And finally, it may be related to your culture, your religion. And these are very important things that we cannot ignore. So we tend to take a model that combines biological factors, psychological factors, social factors, environmental factors, and cultural factors. I think when we put all of these together in a basket, then we can say a certain condition is related to gender. It's not necessarily because of their genetic, but it's also because of their genetics, also because of the environment that they live in, maybe because of the religion. And people have no choice where they live. People live in slums, they didn't choose to go there. And the people who live in different, not so much in slums, they were lucky to be there. And people living in certain areas may have different types of mental illness that are basically affected by their environment. So it's not so easy to say, to pick on men or to pick people, women, in my view, without understanding the total environment in which they live. But having said that, there are certain conditions when we have taken all these things into consideration for a long time, there seems to be a consistent pattern where gender plays a very important role. But even so, must be interpreted in the total context in which that male or female is living in. So to get back to your question, are there certain conditions that we seem to find more in men and the female? I think I'm told that you did a study on, I mean, you had a talk on the gender issue. We do know that, and it has been shown repeatedly, that females have a higher level of depression for various reasons. They tend to be very responsible more than men. And they get very much emotionally involved in the way they bring the families. And we also know that even though they undergo a lot of stress, men are the ones who tend to commit suicide because they cannot tolerate a lot of stress, and so on and so on. Because of cultural factors, they may take to drinking, and we know, or taking drugs, and we know if you take alcohol for some time, it may produce psychotic features, and so on. We also know that because of cultural factors, men may be under a lot of stress, cultural stress, to do certain things which men don't do. We know, for example, that men are more likely to be admitted, given equal chance, men are more likely to be admitted in a psychiatric hospital like we have at Mathare Hospital. And this is not because necessarily of their genetic factors, because of the environmental factors. They are supposed to provide for the family, so under a lot of stress. And I've just said, men have lesser capacity to deal with the stress than the females, and therefore they may break down more easily. If they are suffering from schizophrenic illness, they may be more predisposed to relapse because of other things that have got nothing to do with their genes. So I think it's very important to take everything into consideration. And I think if you do that, you'll be surprised that there will be very big variations. As you may have been told, there are conditions that tend to occur more in female, and there are also conditions that tend to occur more in males, not necessarily because of genetic factors that may be true, but because of other factors that influence the outcome as to what kind of illness a person is going to develop.
So thank you very much. I think I like the way you brought out the point that the consistency in having certain mental illnesses in men is brought about by many, many factors, externally and even internally, so as not to increase the stigma that men are more likely to get it than women, but rather there are other stimulating factors, perpetuating factors around it. And on the depression note, I think I saw something that besides women being more attentive to their feelings and emotions, they're also more likely to seek care. And that's why with research, we're able to pick them in those studies that we do. Men are less likely to come forward and say, I'm feeling sad.
Oh, yeah. I mean, what you're saying is very true. I mean, as a practicing psychiatrist, the people who come to talk about what they are feelings or what, I mean, the condition that they have, maybe depression, women are more likely to come forward and talk about how they feel as compared to men who just, because of their ego, would not want to go on. Therefore, they tend to be left behind. And therefore, you get the impression that females have more of these problems. It's just because they come forward and we see them. As opposed to men who don't come forward to when they have problems. And the only time that we see them is when they have reached a situation where they become psychotic, they cannot relate within the family situation, they cannot relate properly at work, they cannot relate properly with their with other situation, just because they have done little to mitigate the development of this condition to that level. So again, it's not really, you can see very, very clearly, it's got nothing to do with their genes. It's got everything to do with the culture, basically with the culture. They don't want to, it's not manly to, for a man to come out and say, I'm having this and that. Because I'm strong, so I can continue being strong. That kind of attitude. It's a common thing that you see in family situations. It's only the female who goes first to look for help for those reasons.
So men don't have that cultural permission to come forward when they're having the symptoms of depression.
Yes.
And since we're talking of depression, which I think is also one of the sources of psychosis, could you tell us a bit more about that?
Yes. Sorry, you are cutting.
Okay.
Do you like to repeat? Yes.
Depression can lead to psychosis, which is what we're talking about.
Yes.
Yes. So my question is, because of the way.
You're frozen.
Okay. Am I audible now? Hello?
I can.
Am I clear now?
No, I cannot. Yeah, just say it again, see whether I hear you.
I'm saying depression can be one of the causes of psychosis.
Yes, severe depression.
Severe depression.
And it takes this form. When you get psychotic features in severe depression, is very different from the psychotic features that you get in schizophrenic illness. A person who is depressed can hear voices, and these voices are abusive, mocking him, even telling him that he's useless. And he agrees because of his hopelessness, because of what he's going through, because they are not able to do what they want to do. He says, yes, those voices, they are really describing me. That's me. They are correct. We call that mood congruent psychotic features, in this case, hallucinations, or even delusions, if they think that they are totally useless, like a syndrome called Cotard syndrome, which I have seen not very many cases here, where they say they feel that they are so useless that they are better off dead, and they agree, and they say, yes, I need to die because I am totally useless. I cannot do this and that. Yes, as opposed to schizophrenic patient, where if they hear voices, they don't get amused because those voices, they are not what those voices are saying, and therefore they react violently to those voices. So in one case, in schizophrenic patient, they don't accept those voices. They totally disagree. Whereas in depressive psychosis, they say, oh yes, what those voices are saying is true of me. They are different.
Now, on those voices, I think I want to clarify. Are they inside our head, or they are things that you can hear the way I can hear you speak?
Yeah, very good question. It takes a lot of clinical skills to differentiate between the two. But patients who are schizophrenic, they hear the voices very, very clear. The voices come from outside them and they go through their ears, and therefore they can attribute those voices to particular individuals, and so on. It's like either enemies or people who are around in the room, so you see them looking around. The most important thing is that they hear the voices through their ears, and they are crystal clear voices, and they don't take kindly to what they say, except that sometimes they may be saying funny things, and you can see them laughing or smiling, aggressive things, and they react to those voices. As opposed to depressive illness, and where they can sometimes feel as if they are hearing those voices, but more often than not, if you pin them down, they will tell you these are voices that are within my mind. They are coming from within rather than coming from outside. They can present that way, but sometimes they will tell you, I am hearing so and so who is telling me this and that. In that case, if they meet the definition of an hallucination, because an hallucination is a perception. Say we are talking about hearing voices, is a perception in one of the five senses through the ears, and is coming from without. Therefore, you can have hallucination in a depressive phase, that is mood congruent hallucination. They can be understood in the context of the mood that they are going through, as opposed to the other types of hallucination where they don't quite agree. It's got nothing to do with their mood.
Okay. Thank you very much for that clarification.
Yeah.
Yes. So depression can cause psychosis. What are the other?
Yes.
What are the other causes of psychosis? We've looked at schizophrenia. We've mentioned that.
Just before we leave depression, actually, we talk about psychotic depression. There's that kind of depression that reaches such a stage where they are hearing voices, they feel they are totally worthless, and they believe it. It is too a delusion. So yeah, we can get depressive psychotic symptoms. We have talked about schizophrenia, which is very common. Sometimes you can, when people are very manic and they are very happy, they also behave in a psychotic way, which is they may believe that they are rich, they are the richest people, they are the most educated people, they are the best politicians, they should be the next governor. Some of them believe that they are the president and so on. And yet they are still delusions, because of course they just believe in their heads that they are the president, or they are so and so, who is who in politics and things like that. And sometimes they believe in which is psychotic figure, that they may be the wealthiest guy. I met a guy in India who was being presented in a case who used to get manic episodes. And he got into the problem because he was spending so much money, because he believed he was the founder of Tata. You have seen these cars, vehicles called Tata, and he believed actually he was the owner of that company, and therefore one of the richest people in India. And he would act that way and spend money, and before long he would drain his accounts and put the family in terrible situations. Again, a psychotic symptom occurring in a person who seemed to be extremely happy, things are going on so well. To answer your question, you can also get psychotic features in people who have got brain disorder. By that I mean who have damage in the brain, particularly the frontal lobes, this part of the head, where we make all the executive decisions. And it can also occur in very many other parts of the brain. And so people with the psychotic, with the organic condition, they can present that way. A very common presentation that I see here, and is always the first one to present with maybe the presentation with a psychotic condition is a condition that you tend to get very early, very late in life, in the 80s, 90s, where a woman, maybe because of reduced brain function, feel that they are being sexually attacked, and they believe so. They tend to get what is known as psychosomatic condition. I have seen only one man with that condition, and all the other people I have seen, I don't know how many, they have always been women. I do not know why. Is it possible the men don't come forward and talk about it, as we talked about, we said a little bit earlier? I do not know, but you tend to see this condition more in women that age group. You can get psychotic condition because of use of substances, alcohol. There's something called alcoholic hallucinosis, and I'll explain what it is. When a person has got alcoholic hallucinosis, he may hear voices which are very, very threatening. And there's like, when you're sitting in a room, like now I'm sitting in at my working desk at home, you could hear, or even at home where you are, you hear voices of people who are threatening you, and they sound like thugs, making an argument. Let's go in, let's break in, let's kill him, and do all kinds of things. And I mean, and he's hearing those voices. What is this man going to do? He's going to fight, and in the process, he may kill somebody. He's going to run away. He may run through the window, jump through the window, or he may just feel completely surrounded, that he can't move on, he can't move out. Alcoholic hallucinosis is one of the things that you have to look for when people have been drinking excessively. The good thing is, responds very, very, very well to treatment. And of course, because it's found in, I've only seen it in women. I've only seen it in men, because in any case, as we said, they drink quite a lot compared with the women. You can see what looks like a psychotic condition in young girls. This one is found more in girls, and I have seen it. When girls are very depressed, they seem to have visual hallucinations. In fact, somebody who used to work in UK, I think his name was Patel, he said, when you are dealing with young girls who seem to be seeing things, before you think of schizophrenia, think of anxiety. Again, this may be, it's not because of their genes, maybe that's the way they express them, or they are allowed to express themselves. So you can see there's such great variation. So when you see a psychotic symptom, and a psychotic symptom is usually a sign, it can also be a symptom where the patient describes it to you. Try to put it in the context. Just because somebody is having an hallucination does not mean it's schizophrenia. Doesn't mean it does not necessarily mean it's a mood concrete. You have to take very good history to nest that's a psychotic symptom in the most likely psychiatric condition this patient is presenting with. Because as we have said, a psychotic symptom can occur in a variety, and a very wide variety of psychiatric condition. There are other conditions that purely cultural, can only be understood in cultural situation, can also be understood in in relation to the kind of people they are living with. All right. For example, there is a condition that we call folie à deux. This is a French name, but basically these are related to it's related to relationship with the people. You may have a person who is, say, schizophrenic, and he or she has got a spouse. They live together. They are very close. They are very supportive. So you can have a person living with a person with a psychiatric condition, and this person who necessarily does not have a psychiatric condition, does not have a schizophrenic illness, starts behaving and having the symptoms of that person who is having the real condition. We call folie à deux, or it can be folie à trois. These are French names. We are 2 or 3 persons living together. One of them as a primary schizophrenic patient, but all the people living with them in that house, they have that condition. I have seen one case here at Kenyatta National Hospital, a clear case of folie à deux, and we published, I think, a long time ago. It's if you go through my CV, you see that case. We saw it at Kenyatta National Hospital. This can occur regardless of the gender. It can occur either men or female, as long as they are living together. There are other conditions that actually assume almost psychotic conditions, particularly in men, since you are interested in men. We know this as something we called associated with the depression. I mean, with the pregnancy. We are talking about pregnancy. We are not even talking about delivery. Many women who are pregnant may have psychiatric condition, mainly depression. And when they deliver, they can develop frank psychotic symptoms, hearing voices, being deluded, thinking the child is, you have heard of stories of mothers who go and kill their children because they think the children are the source of their problem, and so on. There are men who, are you still there?
Yes.
Hello?
Yes. Can you hear me?
You can hear me?
Yes, I can.
Yeah, there's a condition known as cloudy condition, where men living very close to their wives living together, when they get pregnant, the wives get pregnant, they go into severe depression. And it has been reported, now I think it's common knowledge, it's very well described in literature, that there are men who also suffer from postpartum psychosis. They are not the one who deliver the children, but when their wives deliver and the wife develop psychotic symptoms, they also seem to develop psychotic condition. One time I know one of my pastors some time back, when he was telling us news about so and so had delivered, he would say this: so and so had a baby, she is doing fine, and the husband is also doing fine. They would laugh. See, the congregation would laugh. Why would the husband be getting on fine? So why do you have to tell us he's getting fine? I mean, we expect him to be getting fine. But the truth of the matter is that it's very well documented that there are many who develop those puerile-like symptoms when their wives have their children. And I don't know how much you like us to delve into this issue of men and culture-related symptoms. Let me give you one or two others. There's a condition we call erotomania. And erotomania, I think I have seen it more in men than in women. Maybe because men are more expressive. Okay, so you find it in women, but men are more expressive. And in erotomania, a man believes that a certain woman is in love with him, and he is so much convinced about it, and he achieves an illusion that this woman is in love with me, and you go looking for her, and but for him, if he goes to look for her when the husband is around, more often than not, they get totally clobbered, because the man and the woman does not understand this man could be suffering from this condition. There's another condition which been described mainly in the Far East, we call cross syndrome, which is found mainly in men, although now it can also be found in females. It has been reported in females, where the man, when he is very depressed, he feels that his reproductive organs are getting smaller and smaller and withdraw into the abdomen, and you get very confused about this, and he really believes it, even though it is not really happening. He really believes it, and you come forward and say, well, this is what happened, is happening to me, and they are very convinced, and it's a question of how you talk to him out of it. And there are other conditions that have been found in different cultures, and these are just cultural expressions of these conditions. It's not that there is any genetic predisposition to it. So you can go on and on and on.
Yes. So psychosis is really, really common then, if there are many common causes.
Sorry?
I'm saying psychosis is very common since we have a lot of causes of psychosis. Now, I think
Absolutely, that's the point I'm making.
Yes. So I think someone might be wondering, when you talked about alcoholic hallucinosis, how much alcohol do I need to have in my system, or should I have drunk for me to start getting alcoholic hallucinosis?
That again varies from individual to individual. And maybe these were genetic factors. You know, we like to bring in genetic factors. This is where genetic factors really come into play, in the sense that when we are talking about genetics, the question is, please try to bring it up so that I don't forget. Why is that different people respond differently to different medicine? We'll come back to that. But in alcoholic hallucinosis, there is no clear relationship with the amount of alcohol one is drinking. Some people take very little of alcohol, and they can develop this condition. Other people will take gallons, if I may put that way, and they don't develop this condition. That must be related to their metabolism of this condition, and that is again it depends on the biochemist of that person, which biochemist is so independent of their genetic predisposition. So to answer your question, it varies, and from individual to individual, but whether the person is taking a drop of alcohol and it develops this condition, or is taking gallons of alcohol and they reach a stage where they develop this condition, the presentation is the same and the management is the same. So I don't want to peg it to how much they drink, although on balance, people have reached a stage where they are basically independent on alcohol. And alcoholic hallucinosis does not occur, and I want the listeners to hear this very clearly. does not occur at the height of the intoxication. It occurs when the levels in the body are falling off. So it can occur if they have been drinking in the evening, like now, and they go to sleep. It may occur in the morning because that time the level of alcohol is falling. In some cases, it may be 1 or 2, 3 days since they last took alcohol, and when the level of the brain is falling. So it usually occurs when the blood levels of alcohol is falling down. And as I said, it can be very, very dramatic. But when you see it, it is the easiest thing to treat, very, very easy. Because it's related to a temporary phenomena, falling of brains. You don't want them to you don't want to ask them to go and drink, obviously, although there are times when you may just do that when they are not in a position to take any medicine, or when those medicines are not available. Like, for example, these days we have telemedicine, which we use quite a lot, and you might be sitting in Nairobi and you are taking history in somebody who is sitting in Wajir or Madeira or wherever, and you take the history very clearly, and it is clearly alcoholic hallucinosis. There is no way they are going to get the medicine immediately. Even if you are to send a prescription electronically, they may take several days or so. They may not even have the medicine. So you tell them to stop drinking, and at the same time, they are going to cause a lot of chaos and violence in the house. So you tell them, for the time being, please continue taking little sips of alcohol, and we will get the medicine to you as soon as possible. That is a practical aspect of managing this condition, because you don't want the alcohol to fall to that level where they become violent. They can kill. They can even injure themselves. So you want them to kill or injure themselves because you have told them not to take a sip, or you take a little sip, stay well, be in peace, stay safe, you have relatives, yourself, stay safe until you are able to get the medicine. So that's a practical decision.
Very true. That's what I completely agree with you. You want to keep the alcohol at stable levels so that the person cannot go into, full-blown psychosis and start hurting others.
Exactly. Yes, a practice that is dependent on the circumstances of the patient and how soon they will be able to start taking the medication.
So as we finish on this alcohol,
you are frozen. Yeah.
Okay. As we finish on the alcohol, can you be medicated for alcoholism while still taking alcohol? Can you have both at the same time?
Yes, I will tell you yes and no. You do not medicate them when as a way of treating the alcohol, but you medicate them in this condition even when they are taking the alcohol. When a patient is taking alcohol or is taking a certain drug, you want to know why in the first place they are taking alcohol. Is it because they are depressed? Is it because they are anxious? Is it because, and this is very common indeed, very, 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 very common indeed. Is it because they are psychotic and they are hearing voices? Is it because they are manic and they feel that the life is so sweet, and one of the ways of enhancing that aspect of good life is to take alcohol? So you really want to understand the basic problem that is contributing to this. And this is because we know that people with schizophrenia, with the mood disorders, they have a very, very high comorbidity of substance abuse. And that psychiatric condition may be the real reason why they are taking alcohol. So if you want to detoxify this patient from taking alcohol, of course, when you are detoxifying them, you replace vitamins and so on. And you don't want to go into withdrawing effects and things like that. Is if you don't look for the primary condition, then you are basically wasting your time. If they are drinking because they are hearing voice, threatening voice, and that is the only way they cope with they think they can suppress those voices to the point where they can sleep. If you don't address the primary condition, you are basically wasting your time. So the answer to your question is yes and no, depending on the existing comorbid condition. That is, what else is happening, what other psychiatric diagnosis that person who is taking alcohol, what other conditions and psychiatric condition do they have?
So here you're giving antipsychotics, medication to silence the voices, but you're not withdrawing the alcohol straight away.
No, but this time you are assuming that the patient is already taking medication. I don't think you are going to continue giving a patient to suppress the psychotic, the voices, without treating the alcohol. I don't see how you do that. So it's a combination. It's a multifaceted combination. You treat the alcoholism by withdrawing the alcohol, and at the same time putting them in the on medicine that is going to reduce that those voices. It can be done at home, by the way. If you have talked with the patient ready to understand, they are willing to support and support the taking of the medication, and there is an element of cooperation. Everybody in the family understands that they need not go to hospital. It can be done at home. But that needs a lot of discussion of the logistics of doing that. Will the patient take medication? Will the relative be there to make sure that they take the medication? Are the relative going to be willing to act as, quote unquote, the nurses for this patient at home, this patient being nursed at home, as opposed to being nursed at hospital? And let me tell you another thing that is coming very, very fast. There are very good nurses or other people, not necessarily nurses, who have been trained on home care. And they go and nurse the patient at home. It reduces the cost to the patient. And I think all of us as doctors, we must always think about the cost of doing things. You see, in UK, for example, with the best, I think they have the best health services in the world, funded fully by the government. They make sure that no 1 cent, leave alone, let's say £1, that is spent without thinking whether there were other ways of spending less than £1. And I think it's beginning to happen. Sometimes, I'm sorry to say, there are indications for hospital admissions. I'm sorry to say, there are other situations when the motivation is to get money out of that patient. I leave it to the doctors to decide to make that moral decision. Have you heard of patients being admitted in gunpoint? As it were, I'm not saying you draw a gun on them, but it's like you must be admitted in hospital. This is terrible. This can only be managed in a hospital setting.
Yeah, I've had that. Yeah, I think that's the sad part of medicine, isn't it? So now coming to the treatment, I'm saying coming to the treatment, you mentioned that alcoholic hallucinosis is very easy to treat. Maybe you can try and
Yes.
that for us. How easy is it? Like how many days, how much medication, and how long?
Well, it depends. It depends on the kind of antipsychotic. They normally respond very well to antipsychotics, and they so well that you don't need more than 1 week. It's just like somebody who has been taking cannabis, for example. They may develop cannabis-related kind of psychosis, and once you stop the cannabis, them taking the cannabis, the psychotic symptoms disappear within a very short time. And we also see, well, let me not mention that. I mean, let's talk about that because I think it's politically sensitive. So we leave it alone. But let's talk about cannabis. Cannabis-induced psychosis. If you withdraw the cannabis, the psychosis disappears within a very short time. Actually, within a week.
Okay.
Yeah.
After that, if the patient completely withdraws the, let's say the trigger here, the alcohol, the cannabis, the substance abuse, they don't need to continue taking the medication for a long time.
Once you treated the associated psychiatric condition, I mean, if you are talking about schizophrenia, for example, schizophrenia may take protracted treatment, so you may as well continue treating the schizophrenia as on its own merit. If you are dealing with a mood disorder, say a person is manic, you need to give medicine to reduce the manic episode. If the person is depressed, you give a antidepressant to bring it back to the normal situation. If it's because of a medicine that he has been taking, then you reduce the medicine. Did you know that we are just coming out of the COVID, right? And one of the treatment prescribed for COVID is high steroids. Yeah. Okay.
Yes.
I have seen long before we only started hearing about COVID about 2 years ago, something like that. But long before, we have always known of steroid-induced psychosis, where people took steroids for some other reasons, or they took steroids as a way of strengthening their bodies, and they developed, not all of them, but a very small percentage, they developed psychosis. But in the treatment of COVID, they were given considerable amounts of steroid-related conditions, and many people developed psychotic features. And the treatment, of course, was to continue treating giving medicines for the COVID-19, and at the same time, if you saw the psychosis, then you start treating that psychosis using standard antipsychotic drugs that are widely available in this country.
No, I think that's the other aspect. We've talked of psychosis from psychiatric causes, psychosis from surgical conditions like having a tumor in your forehead or having a structural problem. Here, I would like us to also look at causes, medical causes like stroke patients. A patient is hypertensive, they have high blood pressure, and then they get a stroke. Or diabetes, and then they get a stroke.
But yes, of course, if they have that, then you treat the physical condition, and at the same time you treat whatever psychiatric condition that they may be presenting with. And if they are having a physical condition presenting with a psychiatric condition, my experience has been that they respond very well to treatment. They should, more often than not, they respond very well to treatment. Like this other condition I was telling you, women in their 80s and 90s developing psychosis. Did I tell you that they respond very well to treatment, and they respond very well to small doses? So if you are dealing with a psychosis that's related to a physical condition, the psychosis itself tends to resolve very quickly on the treatment, but then the physical condition may continue. But There's a very important point that I want to make. And maybe this may be the highlight of our discussion. Every time I attend international meetings, there's one session that is attended, that is overbooked. And they usually choose the biggest hall for meeting at that venue. And the people go there, sit on the floor, the place is completely filled, and sometimes they have to put monitors outside. And these are the sessions that are talking about, like, how do you manage treatment-resistant schizophrenia? How do you manage treatment-resistant schizophrenia? Can you hear me?
Yes, yes, yes.
Yeah. And I would like to see your face also.
Ah, okay.
Yeah, you have disappeared. So what I am saying is this, is that there are situations when, say, you are treating depression. There are situations that you use all available medications and nothing seems to work.
Yes.
It's very, very common. In fact, the first time this issue was brought out in the treatment of schizophrenia was way back in 1898, when somebody said there are certain types of schizophrenia that, of course, they didn't have medicine that time, that if you leave them alone, they will get better with the time, or they may just keep on galloping, moving on, up and down for a long time. But there were certain types of schizophrenia, it didn't matter what you did, they seemed to go down. They were resistant to whatever form of treatment they were giving that time. Now, what we know now is that we are so different. Even though they may be a genetic, this has something to do with the genes, not so much the environment, it's got something to do with the genes. And when the genes find expression they find expression in the biochemistry. But we also begin to realize that certain condition like schizophrenia is not just necessarily than what we call neurotransmitters. I don't want to be technical. The chemical changes that are brought about by the genetic predisposition. But we are beginning to realize that's something to do with the nerve connections. And the nerve connection may be, if you check the head like this, the connection be from one side to another, from the front to the back, and from one side to another, and up and down. So there's that possibility. Now, for individual reasons, for different individuals, these biochemical changes may vary subtly, in a subtle way, but still persistent, because you know that genes are under the control of DNA, and all of us have different DNAs. So we cannot expect the different DNAs to behave the same in exactly every individual person. I get amazed. Not a long time ago, you and I, the things that we read in the books, we read about maybe 5, 6, 10 different types of, say, depression, for example, for the sake of argument. But they are saying that actually we have more than different variations of depression, depending on individuals. Now, what we don't know, because we don't have the technology now, is when you start with a medication, you don't know exactly what medication they would respond to. So, to be practical, you start with the more common antidepressants that are available, and assume the majority of patients will respond to these more available antidepressant. And if they don't respond to that, you can go to the next group, you can go to the next group until you reach what is they claim this is the cream of the treatment. This is the best that has been demonstrated. But we also know that you give the best and they don't respond in some cases. So we start talking about treatment-resistant depression, schizophrenia, whatever it is. Now, an analogy that many of us will understand is that if you go to see a doctor with infection of some sort, maybe infection in the throat, infection, say, with a urine infection, that they may do standard, they may just say many people with this condition will respond to this. So you tell them, I'll start you on this medicine, but before I start you on the medicine, go and take your urine or your throat swab and do culture and sensitivity. Okay, and that culture and sensitivity will tell you the exact medicine antibiotic that's going to be useful for you. You know that, everybody knows that. Sindivyo. So you may have people having the same kind of sore throat, but they will respond to different types of antibiotics. And now, so we ignore, by doing culture and sensitivity, we can go straight to the appropriate antibiotic for that particular person without guessing. Unfortunately, we cannot do that. We don't do culture and sensitivity to people with mental illness because there's nothing to do that. But let me tell you what is happening. I know a guy from Germany, is a good friend of mine, kind of spearheading this kind of research, where they are going beyond they are going through what is known as psychogenetics of a particular mental condition, going through the psychokinetics, how the different medicines act in the body. But they are going to the stage where they can actually do a test on your genes and tell you this is antidepressant that you are going to respond to. And it is a dose. So you don't have to treat by trial and error, which is what we do all these hours this time, and because we don't have the technology, but the technology is coming up. By the time you be a senior psychiatrist, you just send these people for take blood, send it for genetics, and they will come and tell you this is the antidepressant that you are going to work on. We are moving into that direction. And the research is very, very active.
Because we get a lot of patients at malaria as well who have treatment resistance.
Sorry, I missed what I missed the beginning of your question.
I'm saying we do get a lot of patients with treatment resistant depression, treatment resistant schizophrenia.
Yes.
And we've explored all available resources to address their deteriorating symptoms. So I think, yeah, that would be groundbreaking and helpful. Now, Professor Ndete, I think we've come to the end of our presentation today. Thank you very, very much for making the time. And I think we need a part 2 to be able to complete this discussion. So I think we can arrange that, and then.
Okay. All you have to do is arrange with my office, not directly with me, but with my office.
No problem. Thank you very much, Prof. And for those who are listening today, thank you very much for participating, and see you next Saturday. So 1 second.
Thank you very much. Yeah.